And we're back with more film identification. This time we'll be talking about rib exams. Ribs should be positioned based on where your patient's injury is. If your patient's injury is in the front, put that injured part against the bucky. You'll get better detail on those ribs. If their injury is on the back, turn them around. Have their back against the bucky, both for your upper ribs and your oblique projections. Some departments also include a PA chest with every rib series. That's kind of what you're seeing here, but this could also be a PA bilateral ribs image. All of the models in Merrill's tend to be showing bilateral rib studies. Those are not as common as a unilateral right or left rib series. So your centering changes, your collimation for sure changes, and because those are more common, that's what I'm going to devote most of the image analysis to, unilateral images. If you have bilateral, it's easy to position. Just center your patient and go. If you have unilateral, then your light field should stop either at the spine or the sternum. And on the opposite side, just past the skin line. Your marker up in the corner above the shoulder. You want to use 14x17 cassettes in a lengthwise orientation, or a 14x17 detector, and then collimate down to the side of interest. If you have a larger patient where you cannot see the skin line because of adipose tissue, then you should keep an eye on the humeral head. As you can see, there are no ribs extending past the humeral head. So you can collimate to that point and rest assured that your ribs will be included. This is a unilateral right ribs. I recommend marker placement up in the corner, even though it's overlapping shoulder anatomy rather than down and bottom. So this could be AP or PA. It's important that you annotate that for the radiologist so they have all of that information. Collimation, we could improve collimation on the medial side. We just need light to the spine or the sternum here, because the left side is not the area of interest. Some sites will want a BB marker on your patient to mark the site of the injury. That's what you're seeing here. And in terms of counting, be very comfortable, not only as a student, but also a tech, counting ribs on your rib series. Make sure that all 12 are included. First rib juts out anteriorly and curls down a bit. So it's going to look the strangest of them. 2 and 3 might be a little overlapped, all the way down to 12. Don't worry if you don't have all of the lower ribs on your first image. We have a separate lower ribs projection coming up. The ribs originate by the spine. So you're looking at the posterior ribs here, and then they curl around and move anteriorly. So in terms of counting, it's always better, I've found, to start at the source and then follow it around to these anterior axillary ribs. It's difficult to count sometimes if you just try and go from here and here, which one you're actually looking at. So start at the source, and then follow that around. Your rib should be exposed on full inspiration, which may be a little difficult for patients with rib injuries, but we need a good backdrop of air in the lungs as a visual contrast, which makes potential rib fractures stand out better, white against the black and the air in the lungs. So your rib series is typically upper ribs, AP or PA. On lower ribs, it's always done AP. And then 2 obliques. The side of interest, you need both obliques. You need one that elongates the ribs and one that foreshortens the ribs. And you can do these AP or PA obliques. In this case, we're looking at an AP oblique rib, and the patient is left posterior oblique. So this patient is LPO. That is going to elongate the left side ribs and foreshorten the right side ribs. If your patient were rolled the opposite direction, an RPO position, the right side would be elongated and the left would be foreshortened. We typically do ribs upright, but if your patient is unstable, standing, you can do all of the rib series on the table. I just recommend that you do the obliques AP so that your patient doesn't have to turn onto their stomach. But in this case, we're elongating the left side of this patient. Marker placement up here, behind his arm, another 14 by 17 lengthwise cassette. And if you're just interested in the elongated side, your light field should extend from the skin line to all of the patient's neck. We don't need to go all the way over. We do not need the entire cassette. You can collimate in a bit, even for the elongated ribs. If you get light covering your patient's neck, you will get everything. They're elongated. You want to oblique them anywhere from 25 to 45 degrees. You don't need a super steep oblique for ribs, but if you don't turn them enough, then it looks very similar to your upper ribs AP or PA, and then you need to repeat it. Now this is a PA oblique. Your patient in this case is an RAO position. And the information will be very similar to this projection. So RAO, patient against the bucky. The ribs that are against the bucky will be foreshortened. The ribs that are pulled away from the bucky when the patient is facing it. Ribs that are pulled away will be elongated. So if we are looking at the left side of this patient in an LPO position, we're elongating the left side. We turn them around. Now the left side is pulled away. It will also be elongated. So the AP and PA obliques are opposite each other. If you just memorize one set, which way you roll them, which way it'll elongate, then you can just reverse it. So an LPO and RAO will have the same rotational effect on your patient. This is a bilateral oblique rib projection showing you the difference that you will see when you elongate one and foreshorten the other. So in this case, your patient is either in a left posterior oblique or a right anterior oblique. Note that if you were just looking at this half and you got light across your patient's neck, you would have all of those elongated ribs. So what can we see here? Rib number 1, 2, 3, these are all posterior ribs. Where they're curling around, it's sort of, you're looking at it on end here. On the foreshortened side, you also have posterior ribs and then curling around. So you're looking more at these axillary, the anterior side on the foreshortened image. So here's rib 1, 2, 3, 4, rib 5 curling around to here. Right clavicle, left clavicle, distorted up here, your acromion, scapula, and rib 12, hard to see, but down here. BB marker, so this patient is injured on this side. Here's a much better collimated, elongated right ribs. So again, this patient is either RPO or LAO, focused on the right side. And this image helpfully marks all 12 ribs for you to see. Note how close 1 and 2 are up here. It can be a little difficult to separate visually, but you should be able to count them pretty clearly. And if you can't identify which is the first rib, you should be able to identify 12 and count backward. Here's your right clavicle, again, looking very distorted because of the steep angle. Acromion, coracoid, right scapula, left clavicle. So our manubrium of the sternum is here. Body of the sternum kind of superimposed down here. Scotty dogs, indicating that this patient is rotated somewhere in the realm of 45 degrees. Another elongated right ribs. This one, collimation could be improved a bit. We don't need the left side, but we also don't want to clip. So you're giving yourself a little bit of wiggle room here by having the light pass the spinous process. This is the same image from before, the bilateral rib projection, just cropped so that you would see much better collimation for a unilateral foreshortened ribs. If you're positioning for these, you don't need light covering all of your patient's neck. You need light going from the skin line to the jugular notch, or the spinous process of the easily palpated C7. That will get everything that you need on there. Note that this patient does not have scoliosis. Just the rotation is enough to sort of angle the spine and the ribs a bit. And the steeper that you make this, the shorter this space becomes. You don't want this too steep. You also don't want it looking just like an AP ribs, so split the difference. But if you start really narrowing up here, you have obliqued your patient too much. So first rib, second, third, fourth, fifth, sixth, seventh, eighth, ninth, 10th, 11th, 12th down here. So you're seeing the originating part here and then swinging around the anterior side. Finally, we have AP lower ribs. The lower ribs do not come around all the way to the front of the torso, so they are always done AP. You want to get those ribs closer to the image receptor. Also very important that you expose this projection on full expiration. We want to elevate the diaphragm and see the ribs against the backdrop of the abdomen rather than the air in the lungs. Now, some facilities do their lower ribs bilateral, even on a unilateral rib series. I have never had any complaints for turning in a unilateral lower ribs on a 10 by 12 cassette or light field. So for this, if you're going to do a unilateral lower ribs AP, you have your 10 by 12 field lengthwise. You want to feel for your patient's iliac crest and have no light going below the crest. There are no ribs below the iliac crest. So it just gives you the bottom portion, and then you should have light to the mid-chest, the sternum, and light to the skin line. Marker is going to go in the bottom corner on an AP ribs. Note the difference if you have your patient breathing in for this projection. We can still see 12 and 11, even though this picture quality is very poor, but it's difficult to discern fractures on 9 and 10 here compared to on this projection. And again, make sure that you have 12 visible and all of the other lower ribs visible, not clipped off. You should be able to see L1 below T12 that has no ribs on it to make sure that you have everything that you need. If you clip off the end here, you need to repeat it.